Hello everyone. Today, management of preeclampsia. How will we assess preeclampsia? Assessment of women with preeclampsia should be performed by a healthcare professional trained in the management of hypertensive disorder of pregnancy. Carry out a full clinical assessment at each antenatal appointment for women with preeclampsia and offer admission to hospital for surveillance and any investigation needed. If there are concerns for the well-being of the woman or baby, concerns could include any of the following: sustained systolic blood pressure of 160 mm mercury or higher, any maternal, biological, or hematological investigations that cause concern, for example, a new or persistent rise in creatinine 90 micromole per liter or more, 1 milligram per 100 ml or more, or rise in alanine transaminase over 70 international unit per liter or twice upper limit of normal range, fall in platelet count under 1,50,000 per microliter, signs of impending eclampsia. So we will see the blood pressure, whether it is above 160 or not, systolic, maternal biochemical or hematological investigation, creatinine, alanine transaminase and platelet count, creatinine 90 microliter or micromole per liter or more, 1 milligram per 100 ml or more, alanine transaminase over 70 international unit per liter or twice the upper limit of normal, reduced platelet count under 1,50,000 or per microliter, signs of impending eclampsia. And signs of impending pulmonary edema, other signs of severe preeclampsia, suspected fetal compromise, any other clinical signs that cause concerns. So blood pressure, one parameter is blood pressure, biochemical, maternal biochemical and biochemical investigations, then signs of impending eclampsia, signs of severe preeclampsia, impending pulmonary edema, suspected fetal compromise, any other clinical signs that cause concern. Consider, when using a risk prediction model, take into account that either full PIRS or PrEP-S validated risk prediction models to help guide decisions about the most appropriate place of care, such as the need for in utero transfer and threshold for intervention. When using a risk prediction model, take into account that full PIRS is intended for use at any time during pregnancy. PrEP-S is intended for use only up to 34 weeks of pregnancy. Full PIRS and PrEP-S models do not predict outcomes for babies. Treatment of preeclampsia. Offer women with preeclampsia the tests and treatments listed in Table 2. Hypertension, severe hypertension, blood pressure 140/90 to 159/109, that is below 160/110, and severe, that is above 160/110 millimeter mercury. Admission to hospital, only hypertension, admit if any clinical concerns for the well-being of the woman or baby, or if high risk of adverse events suggested by full PIRS or PrEP-S risk prediction models. And in severe hypertension, admit, but if BP falls below 160/110, then manage as for hypertension. Hypertensive pharmacological treatment. In hypertension, offer pharmacological treatment if BP remains above 140/90, and in severe hypertension, offer also pharmacological treatment, obviously. Target blood pressure once on antihypertensive treatment. Aim for BP 135/85 or less And in severe hypertension, also 135 by 85 or less. Blood pressure measurement at least every 48 hours and more frequently if the woman is admitted to hospital. Every 15 to 30 minutes until BP is less than 160 by 110, then at least 4 times daily while the woman is in hospital is an inpatient depending on clinical circumstances. Dipstick proteinuria testing. Only repeat if clinically indicated, for example, if new symptoms and signs develop or if there is uncertainty over diagnosis. Only repeat if clinically indicated, for example, if new symptoms and signs develop or if there is uncertainty over diagnosis. Blood test. Measure full blood count, liver function and renal function twice a week. And in severe hypertension, measure full blood count, liver function and renal function 3 times a week. That is in every alternative day, and only in hypertension twice a week. 3 days interval, 1 day interval. Fetal assessment. Offer fetal heart auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus at diagnosis. And if normal, repeat every 2 weeks. Carry out CTG at diagnosis and then only if clinically indicated. Offer heart rate auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus at diagnosis and if normal, repeat every 2 weeks. Carry out a CTG at diagnosis and then only if clinically indicated. Offer labetalol to treat hypertension in pregnant women with preeclampsia. Offer nifedipine of women in whom labetalol is not suitable, and methyldopa in whom labetalol and nifedipine are not suitable. Base the choice on any pre-existing treatment, side effect profile, risks, and the woman's preferences. Record maternal and fetal threshold for planned early birth before 37 weeks in women with preeclampsia. Threshold for considering planned early birth could include any of the following known features of severe preeclampsia. Inability to control maternal blood pressure despite using 3 or more classes of antihypertensives in appropriate doses. Maternal pulse oximetry less than 90%. Progressive deterioration in liver function, renal function, hemolysis or platelet count. Ongoing neurological features such as severe intractable headache, repeated visual scotomata or eclampsia. Placental abruption, reverse end diastolic flow in the umbilical artery Doppler velocimetry, a non-reassuring cardiotachograph or stillbirth. These are the indication for termination, early termination. Other features not listed above may also be considered in the decision to plan early birth. Be aware that some pulse oximeters can underestimate or overestimate oxygen saturation level, especially if the saturation level is borderline. Overestimation has been reported in people with dark skin. See also NHS England patient safety alert on the risk of harm from inappropriate placement of pulse oximeter probes. Involve a senior obstetrician in any decisions on timing of birth for women with preeclampsia. Discuss with the anesthetic team if birth is planned in a woman with preeclampsia. Discuss with the neonatal team if birth is planned in women with preeclampsia and neonatal complications are anticipated. Offer intravenous magnesium sulfate and a course of antenatal corticosteroid if indicated, if early birth is planned for women with preterm preeclampsia and birth. Decide on timing of birth in women with preeclampsia as recommended in Table 3. Timing of birth before 34 weeks. Continue surveillance unless there are indications. Recommendation 1.5.7 in the section on timing of birth for planned early birth. Offer intravenous magnesium sulfate and a course of antenatal corticosteroid in line with the NICE guideline on preterm labor and birth. From 34 weeks to 36 weeks plus 6 days. Continue surveillance unless there are indications for planned early birth. When considering the option for planned early birth, take into account the woman's and baby's condition, risk factors such as maternal comorbidities, multifetal pregnancy, and availability of neonatal unit beds. Consider a course of antenatal corticosteroids in line with the NICE guideline on preterm labor and birth. 37 weeks onwards, initiate birth within 24 to 48 hours. Postnatal investigation, monitoring, and treatment, including after discharge from critical care. Blood pressure. In women with preeclampsia who didn't take antihypertensive treatment and have given birth, measure blood pressure at least 4 times a day while the woman is an inpatient. At least once between day 3 to 5 after birth, on alternative days until normal if blood pressure was abnormal on day 3 to 5. In women with preeclampsia who didn't take antihypertensive treatment and have given birth, start antihypertensive treatment if blood pressure is 150 by 100 mm mercury or higher. Ask women with preeclampsia who have given birth about severe headache. And epigastric pain each time blood pressure is measured. In women with preeclampsia who took antihypertensive treatment and have given birth, measure blood pressure. At least 4 times a day while the woman is an inpatient, while every 1 to 2 days for up to 2 weeks. After transfer to community care until the woman is off treatment and has no hypertension. For women with preeclampsia who have taken antihypertensive treatment and have given birth. Continue antihypertensive treatment for choice of antihypertensive during the postnatal period. Consider reducing antihypertensive treatment if their blood pressure falls below 140 by 90 mm mercury. Reduce antihypertensive treatment if their blood pressure falls below 130 by 80. If a woman has taken methyl dopa to treat preeclampsia, stop within 2 days after the birth and change to an alternative treatment if necessary, because methyl dopa causes postpartum depression. Offer women with preeclampsia who have given birth transfer to community care if all the following criteria have been met. There are no symptoms of preeclampsia.